I hope you're going to hear me. Sorry to say I have a little bit of a cold, but probably this can work out anyway. So what we're going to talk about now, this first presentation, is basically around the work package 4 in Prime Care IT, where we have focused implementation, or actually investigation first and then the implementation of teleconsultation. Later on, we're also going to get some examples, some brief looks at some of these pilots. But I start with a presentation on the context. So if you're looking at the whole intention around such a work package, it was to explore where the teleconsultation and then also telementoring could aid in reducing the possible problem of professional isolation, and also, of course, help where we have less population density. Actually, when you have less people around, of course, the cost is going to be raised in terms of healthcare. So technology can help here. So the whole point was to try out teleconsultation, basically virtually, by using technology, aid professional healthcare workers to get closer to their peers, and also, of course, in the long run, help patients. But if we start looking at a little bit of the aim with the teleconsultation work, there was a little bit of a request for primary healthcare workers to investigate in this. And what we were aiming at in Prime Care IT was basically to look at how we could successfully implement and test teleconsultation in pilots. The aim here was to try out 7 pilot sites in remote areas in 5 different countries within this Baltic Sea region. And this is something we also have done. Then the point was to validate these teleconsultation solutions in the remote primary care. And this is also something that has been done. I'm going to report upon the results. And then I think the last task is to prepare the possibility to make sure that these pilot sites grow into more steady state operation in terms of teleconsultation. This is more or less things that has to happen after the project is done, but we also set in place the development of a lessons learned and best practice handbook in order to achieve this goal. So if we go into the objectives with teleconsultation work, there are a couple of objectives that we are targeting here in Prime Care IT. And one is, of course, to enhance the connection of health professionals within primary health care and the cooperation also with the secondary healthcare sector. So when we think about this, the primary goal here is to connect the healthcare workers. So there have been lots of tests before where you put the position of healthcare worker towards a patient. In some of the pilots, this is also the case, but the primary goal here was to connect the healthcare workers. And also another objective was, of course, to enhance the use of technology, basically, ICT, for collaboration of health professionals within primary health care. And the third task was to look at this in remote areas, because this is what is seen as the problematic area. It's very easy to get professionals to work in big cities. They feel confident, they have all the knowledge they need present there at their hands, but as soon as you go into rural areas or less populated areas, you get a problem. And there are a couple of different things around that. One is, of course, you feel isolated as a professional. The other one is actually that you get an insecurity among the people living in an area because they don't feel that they have the right competence at their fingertips. So by using teleconsultation, there's a possibility to achieve this. So if you go through the different work tasks we did in the work package, the first was to start doing the situation analysis. And it is basically to understand how is the context looking in the different countries. We all know we have different healthcare systems, so it's really important to understand what is similar, what is different within the different regions. So this has been done and this is documented. It's possible to download this documentation also through Prime Care IT. After that, we did literature study, and this is basically to understand where the state of the art is in terms of technology. Because teleconsultation, you can actually do teleconsultation just by using a smartphone. You can do it by using Skype or other technology. So you have to do a constant inventory check in terms of what technology is available. And the typical matter here, if we look at this study, is that technology is becoming cheaper and cheaper. So if you go back 10 years, there were people who were talking about cost of 30 to 40,000 euros to implement teleconsultation in terms of technology. Today, it's basically, if you have a smartphone, you can try something out. But then you also have to look into the methods and tools in terms of how you develop and deploy teleconsultation. The third task we were looking into was the needs assessment. And this is to try to find out what do the different regions have, where do they stand, what technology is available. Because it's kind of useless for us in a project to start out by just buying a lot of equipment and then pushing that equipment out to all the different regions and say everybody's going to test the same. So instead here we looked at what was the specific situation in each region, and then trying to do the inventory check and then basically go purchase the right equipment for each situation. After that, it was the process assessment that was done, looking at, since we have the different contexts, healthcare works a little bit different, so we have to deploy a certain process to get things implemented. So that was the one task. Another thing which kind of comes as an unwanted item, but it's always going to show up, is the legal assessments. Whenever you want to do something like this, someone is eventually going to say, you know, we can't do that, we can't break firewalls, we can't do this because of patient safety, we can't do this because of this and that. So we also had to work with that struggle. Part of those questions were then, of course, fed into the Work Package 6 in terms of stakeholder involvement. But in general, we also had to deal with it in Work Package 4. After that, simple thing, just deploy the pilots. It's actually really simple. It's more complicated to get them running up at speed, but to just deploy them is simple. After that, we did evaluation, and this is what is ongoing now. And the next phase, until we quit this project in March 28, is to do the actual best practice handbook. So if we do a quick look, I will go a little bit deeper into this. We have 7 pilots spanning the regions. So you see the kind of geographical region of Prime Care IT covered here. 7 pilots, and down in the right corner we have the basically deploy scheme. If we go deeper into details here, this is how this kind of plan looked like when we were starting out Prime Care IT. And we have milestones that we have to achieve. So we have a couple of milestones, and now we are up here in the final phase of the project. And that basically means that when we're looking through the work process I was talking about, we have made sure we have these outputs. So any person who wants to know more about the project can, of course, after the project is done, start reading these outputs, because you will find all the information there. Here in the center, we have the core of Prime Care IT pilots in terms of teleconsultation. It's each and every individual pilot we are deploying. And I'm going to do a little bit of a quick run-through of these pilots. Just going to make sure I have track of the time here. Yes. So the first one was in Sweden, was with teleconsultation with Wound Care Center. And we're going to hear a little bit more about this one later on, more in detail. But we did get outcomes here. We ran basically 4 different types of teleconferencing, teleconsultation, and they all got an outcome. And basically what we see is that the consultations are working, and we have some pros and cons with them. And since I'm going to go deeper into this pilot a little bit later on, I will not dwell on it right now. The same second pilot in Belarus, looking at professional support of doctors, the general practitioners, from remote areas using teleconsultations. And interesting here, we are showing brief aspects of each pilot, is that you see that you have evaluation criteria in terms of satisfaction when we're running these tests. Pilot 3 was in Finland, and this was central hospital to home care units. And also here, here we have kind of done evaluation in order to get a score for how people perceive doing teleconsultation in this kind of context. Fourth pilot was also done in Sweden, psychogeriatric in distant rural area. Also here, things have been working out fine, and the pilot is finalized and documented. Fifth pilot was with Lithuania, Vilnius University Hospital. And here basically the task was to explore technologies available and see how we could use technologies in these teleconsultation and telementoring situations. Pilot 6 was the Estonian Vormsi Healthcare Center. And I think most of you have seen Madis showing off this equipment outside today. Otherwise, I recommend you to do this because this is a truly mobile unit. So also around this unit, there's been testing and piloting going on. And there's also, of course, in the pilot documentation, mentions on processes, technology, feedback, and everything. And then the final pilot was the National Health Survey. We're supporting GPs from remote areas via teleconsultations. So if I'm going to do a little bit of conclusion around this, the aim was to run and test 7 pilots. Luckily enough, we actually done this also. So all 7 pilots have been implemented. They all measured both the attitude and experience during sessions. So we did look at quantitative data, basically how many sessions you were running, but also the qualitative data. What did people think? How did it work? How did it work around the pilots, basically the decision makers, not only the doers who were doing the teleconsultation. The pilots report back that teleconsultation helped to improve professional capabilities in remote areas. This is one of the goals we wanted to achieve, so that's good. Participants say they felt less isolated, and also having self-confidence in making decisions and solving cases improved. And this is really good, of course. If you're looking at the aspect of teleconsultation as a tool for counteracting brain drain, this was not seen as a fact in the study. So we are not sure if that was really a true cause, because it was not seen. But still, it's a helpful thing to have to make sure that you support, especially the young practitioners going out in rural areas. Because I think having the ability to rapidly connect to a bigger knowledge source is something which is highly sought after for the young professionals. And also we see as a final conclusion that teleconsultation is a modern approach, a good tool to develop professional experience. And also I think it's not a matter of if you should implement it, it's basically around how and how to get it integrated in your daily processes. And if you have more questions on this, you can of course contact me as the work package leader or Sami as the lead partner of PrimeCare IT. So by that, I hope I finished in time. Yes. And I say thank you. And we have questions later.
Okay, so would anybody like to ask the first questions? Do we have a question?
Thank you. Looking at your experiences with the teleconferencing part, I noticed that the Finnish pilot had far the most usage and the best experiences. So first and foremost, Dr. Rindala and also the others, why do you think that is? So is it just the level of technology you chose, the prior experience, IT support, or something else?
Sorry.
I didn't hear properly what was your question. I mean, our experience. You thought that we had the most experience.
Sorry, you had the best experience. So you had a lot of sessions, and your users were very happy with the sessions and with the results of the sessions. In the other countries, very few sessions, and the users were not so happy.
Okay, I don't start to argue with you, but I didn't see that we had the best experience. But yes, we did a kind of questionnaires and then focus group interviews. And of course, focus group interview is a kind of qualitative study. And in that study, all those positive aspects came up. I cannot really say anymore, but I do believe that the others had similar experiences when we have been discussing, so I cannot really say that our experience was unique, but thank you that you appreciated our pilot so much.
If I add to that, I do think that this Finnish pilot was good. I think it was because they had if I was to comment on that, I think they had an intense tech interest and also I think had some built-up knowledge from the beginning. They knew what they wanted. So I think when they started working, I think they knew exactly what pilot they wanted to test. So that was good. But then again, I think we're down to comparing apples and pears. I think the pilots have different context. If I'm looking at, for example, the Swedish pilot with wound care, I think there were fewer assessments. So, I mean, we have to compare what is quantified and what is the qualitative statements. So I think in general, it's really hard to discuss success factors and just have the quantitative numbers because they are very different situations. But I think this is also coming down to the final reporting, is trying to level out and compare, although you have different cases with different factors, try to compare them in terms of, for example, satisfaction and efficiency.
Тобиас, я хочу тебе задать вопрос. Спасибо за великолепную презентацию, которую подготовила Эви. У вас большой опыт по телеконсультированию.
Tobias, we would like to thank you for your presentation and the teleconsultations that were done with the help of Evi's pilot. It was excellent.
Одной из проблем, которую ты озвучил, которая следует за внедрением этих технологий, является техническая поддержка телеконсультаций. Если можно, в двух словах скажи, как вы этого достигаете? Вы давно работаете по этим технологиям, что у вас получается в итоге?
One of the main advantages is your technical support, and you have achieved quite good results in technical support of the project. So what were the steps how you achieved these results?
I assume that, of course, you mean in terms of the pilot, and I think part of that, I think if we're looking at the Swedish situation, has to be that even if I'm complaining a lot on the IT facilitation and infrastructure control we have, it is actually good and it's been working for a long time. So I think that's one of the factors. There is a kind of technology maturity. So we have to say thank you to that, while it is also a kind of a stopping point also, because when you have something which is mature, nobody wants to change it.
I would like to ask you, how did you manage the consultations time, and what do you think, how it should be done in the real work?
I'm not sure I understand the question, but if I look at this, if I take, for example, this wound care pilot, it was done in reality. So this was deployed in real situations with real nurses, real doctors, and real patients. So at least, so it was nothing fictive about that. The fictive thing was that because of IT, we basically broke some protocols and running sessions on the side besides the original IT systems. But it was done live with real patients and real doctors.
Our situation was a little bit different. We had a kind of forum for teleconsultation. So it had a topic, and there was discussion about patient cases which doctors were able to present, and of course this type of conference or session, we just put up the time, so it is from 9 to 10, and that's how it is. If we want to have a consultation, ad hoc consultation or acute consultation with the doctor from home, of course that is a little bit difficult to agree if the doctor has full schedule, so there should be a specific person, specific doctor to be available for consultations. We had a small test with home patients, and their doctor was available for the time when the consultations were going on.
I don't ask nothing, but I belong to the same organization and like Raimo, and I must say that in Kauhava primary healthcare results depends very much that Raimo has been a big motivator in our organization. I think that's why the results are so good.
I buy a cognac for you in the evening.
I would like to give a question to Professor Larsson, because he first mentioned legal problems. Some patients get improper treatment or even damage to their health. In that case, when a mistake is made by the consultant, the doctor of the hospital, who is responsible for insurance company or to the lawyers if the patient gets mistreatment?
That's a spot-on question, one of the biggest ones. In general, I will say that the same procedures are in place as it is today. So as you look at it, for example, if you have someone responsible for the patient, it doesn't really matter how many people you ask, whatever you do, you are still the responsible person. So even if you take advice from somewhere else, it's still down to the doctor who has the responsibility for the patient. But this is something which, of course, people have to look at in the future. Because if we are going to deploy these systems, this is going to be a huge discussion in the future, especially if we go to whether written documentation, written transcriptions, whatever it is, whether they are right or wrong. But today it's the same as it's always been, it's the doctor.
The same in Finland. Even you ask advice and you use the guidelines, you are responsible for your decisions.
Okay, I have a question concerning data security. Mr. Snowden revealed certain documents that shocked the world, and how has this influenced the e-health community, and has there already been increased demand for data security, and what do you think, how will the patients behave and the healthcare professionals in the future? Are they going to be more worried about what data is being shared and to whom, who's reading the data that's saved?
I mean, that's a very open-ended question because it hits a lot of actors. I think first we're going to see a change in the future where I think the patient, we as persons, are going to own our own data. This is going to be challenged all the way until we actually have that decision. But today I think this is why, I mean, again, I'm complaining on my IT departments, but again, they're doing a good job because they don't want to release a lot of data before they know what is actually happening. So this is what we see. If you start working with video and audio, you need encryption of that. And when you have it stored on hard drives, etc., how do you make sure that you have the data security? But on the other hand, we can also ask the same question, go back to our paperwork we have today. We have paperwork in file cabinets. How do we make sure people are not reading that? Whatever we do with data, we can actually track, but you don't have control of how many people have actually read a physical file. So at the same time, we have to think about that the systems of today are not 100% secure. So whatever system we're moving into is better, but at the same time, we have to look into ethics and data security, which I think most people are doing at the same time.
And I do believe that every country has auditing system, and for instance in Finland, before we can have that electronic patient record, it is auditing and our security systems are audited, and twice a year we are auditing, for instance, some important persons who has been looking their data if there are cases which are not related to healthcare, and for instance they are looking whom I have been, whose papers I have been visiting, and making sure that I am not visiting without any reason patients' data.
Thank you. I will go to the more soft issues, from the hardware issues to motivation. You have all presented that motivation within staff is a crucial factor for further implementation. And I wonder, I know that you don't have any figures or facts, but what are your thoughts? Have you any ideas on how to counteract this and how to enhance them or increase the motivation? Thank you.
Hello. Oh, okay, working. In general, motivation is a really important factor for the participating in every activities, and probably we are here in this conference because we are motivated to listen to the presentations. So participation in telementoring or teleconsultation, motivation of participation is also important. And of course, motivation can be increased by political decisions. If we make a system that people are will be by the decisions involved in activities, or also it can be motivated by the financial issues, also by having infrastructure, by having every what they need to implement activities. And if this will be in daily routine, so this motivation comes not so much important when now we had the implementation of pilots. So piloting is, of course, motivation is more important. But if this practice become routine, probably we will do it as it is our daily practice. So then probably motivation will be less important.
I can see the same way, like you do. When you from down to up, then when you have a good project leader like Raimo, then it's already something. Then you're going up, that you have a management support of one organization, which was also issue before, that in one organization things are moving faster, the data seems secure. But when you start to work with different organizations, you have to have a political support and infrastructure. So I think this is what also Ketrius wanted to say.
I would like to add that motivation means that I want to gain something. I'm envy to somebody who is better than me, and I want to be better than he or her. And the gaining something can be material or immaterial, and in our case it's very often immaterial. It's empowerment of staff to use their skills and knowledge. And I think that it goes further. It's empowerment of the patient as well, and maybe in the future empowerment of the patient and their demand for ICT information and their own data is the driving force. We have to face those needs.
In the morning we discussed about education, and in our former Interreg project, ICT for Health project, one work package was how to develop e-health education. And we made a survey in Baltic regions, states also, and we noticed that we have a lot of e-health education for healthcare professionals, but we should develop the content of education. So we should have multi-professional education for healthcare professionals, and one result was also European e-health master program for healthcare professionals. But now I would like to ask you, after piloting teleconsultation, tele-mentoring, how do you see need for education, e-health education, basic education and further education for healthcare professionals, medical doctors and nurses and other professionals? Thank you.
Well, I can see that that would work on a couple of levels. First of all, we shouldn't over-mystify a lot of things. I think what we see already today, we see this in Blekinge in our education. I mean, when we educate the nurses, they are being taught entrepreneurship, some aspects of technology. This was previously very unusual to be seen, but we see it today because you constantly have to reinvent your workplace. So we want the nurses to be innovative. We want them to adapt to new scenarios. So on one level, I think it's small changes in existing education. So that's one part of the answer. The second part is that we're going to see a whole new profession coming in, which is health tech workers that is coming into hospitals. So which are basically there to find the needs, develop solutions, software, technology, etc., put them in place and make sure they are working. And these persons basically have to have some clue about health as such, but also be, in general, very good in technology. And these are areas where we see education is popping up. You can call it applied health technology or whatever. So I think it's both educating or putting more pressure on the health workers and also educating a new breed of workers, I think.
Also, what we have after implementation of telementoring programs, we understood that in each country that participated in pilots, professional education already is regulated. But only what we did new, this is we used for professional training and education IT technologies. So very important thing is after implemented pilots that those programs that we have implemented and our professionals has participated in education, that this education that was provided would be accepted by the credit systems or by the regulating agencies, that it could be certified somehow, and that these people would feel that they also this system working not only beside regular system, that they also need to gain additional credits after telementoring or training on IT. So this is same legal questions that is still not solved in all countries, and probably if this would be also legally regulated, it would be also more attractive to participate in telementoring programs.
When we learn more about ICT and learn to use it, I feel that we all the time find new possibilities how to use it. But related to education, I do feel that we should remember that old methods in education, we cannot just transfer them into ICT. We must comply with the new strategies like adult learning methods and lifelong learning methods, multi-professional methods and so on. Yes, for sure, it has a very important role, but as well I am very much promoting that at local level we should be able to empower the local skills and knowledge in use of learning, not only from up down, because adult people, persons, professionals who have been working 30, 40 years in a they have plenty of skills and knowledge which they can use if there is just a possibility for that.
Okay, thank you very much. I'm sure there would be many more questions, but unfortunately that's all we have time for. Thank you very much to our Session 4 speakers for their contributions today.